one of the things that we looked at was how can we take some of the best techniques that are out there for patients and really pool them in one area that provides four different pillars of treatment that dealing with some of the best regenerative medicine by Regenix in order to be able to heal patients so that they are not needing surgery for traditional musculoskeletal type treatment options. Second, by looking at neuromodulation, which deals with the brain, the nerves, and other aspects of the nervous system to be able to improve overall functioning of patients. Number three, to be able to look at integrative wellness, which basically integrates the utilization of alternative therapies, things like yoga, nutrition, and appropriate utilization of functioning. And number four, minimally invasive pain procedures that basically take traditional surgery and make some of those techniques in some fashion obsolete by using minimally invasive techniques in order to be able to get the job done. Today, we're going to talk about treating the complete pain patient, the interplay of mood and functioning, and really assessing patients from a different perspective than what is common with most traditional pain practices. And one of the things that we really look at is what's the cycle of pain and how can we be able to improve patients' overall state and really let them get back to leading the lives that they want to lead. So one of the things that we look at is this quote unquote cycle of pain. And traditionally what happens is there's some type of trauma or insult and the patient gets pain that's present, number one. And then number two, as they get that pain, they start to have that fear of that same trauma or injury occurring again. So it causes them to, number three, have a fear of movement where they start limiting their movement in number four because they're concerned about getting that same insult that they faced at number one. And then at that point, number five, they started having deconditioning, meaning they started having muscle atrophy or muscle wasting because they're not moving those things. It's that pretty common and often repeated adage, if you don't use it, you lose it, right? And then finally, after having that deconditioning that's taking place of the musculoskeletal piece, they also have that mental deconditioning, which basically means that they, at that point in time, feel like they can't do it. And so when we look at patients that have been in the course of having this chronic pain, which is just debilitating, and that just really influences how they deal with the world, how they deal with their support system, how they deal with what they can be able to think about what they're possibly able to do, it takes away their hope. And I don't know how to say that in a more powerful method and manner. It takes away their options for what they believe they can do. And that is one of the most debilitating aspects of getting a good outcome, of getting that patient to feel like they still have control. I understand it from both a personal standpoint for things that have happened to my family, which compelled me to be a doc, and I also understand it in the context of trying to be an advocate for my patients and knowing there are many times where those patients are not able to get a physician to listen to them or give them a way that they can be able to help take control of their own care. So what we really want to be able to do is find a way to be able to break that pain cycle, to be able to utilize the ability for us not to be stuck in just traditional pain management practices. And some of those practices are the following. When we take a look at this graph, we can be able to see that traditionally the patient comes in, they have a diagnosis that's put upon them, they have physical therapy, they may have some over-the-counter type treatment options, then they have another subsequent first tier therapy, which is something like an NSAID, an anti-inflammatory, like a Aleve, naproxen, things of that nature. They may get the aspect of a quote-unquote nerve block, traditional things like an epidural or facet joint injection. It's a possibility that they receive something like a second-tier therapy, which right now has become very taboo, things like opioids, or maybe they have a thermal procedure like a radiofrequency ablation, or is commonly used by many physicians the aspect of saying they're going to quote unquote burn their nerves. And then occasionally, depending on if the doc is quote unquote more sophisticated, then they will have an advanced pain therapy, which will be something like neurostimulation, like spinal cord stim, which does have some degree of value. Intrathecal pumps, which has value in certain patients, or even a surgical procedure if necessary. I'm not stating that these traditional practices will not help improve patients. They can. But what we really need to do is say, can we look at how does this impact the totality of the patient? And frequently it falls short. And when it falls short, it's not to our extent as providers, as healthcare physicians, as healthcare individuals to say, oh, well, it's all we have. There's nothing else to offer. You need to go seek someone else. No, instead, we need to look at this from a different perspective. So one of the things that quotes that Grace Hopper put forth was the most damaging phrase in the entire language. It's just always been done that way. Meaning patients get, well, this is what we can offer to you. I've given you all the treatment that I have. I have nothing else for you. You're just going to have to live with it. And to me, I feel like that's not only an insult to the actual corporeal, the physical body, but it's an insult to someone's mind, to their heart, and their mindset of how they continue to function in this world. As a really common adage that's put out by Albert Einstein, we can't solve problems by using the same kind of thinking that we used when we created them. Meaning we need to think outside ourselves and find a way as healthcare providers for a chronic pain patient, for those who have some of the most challenging life circumstances. Maybe we need to look at this from a different perspective. And so in that context, one of the things that we see is that patients, whether we're talking about chronic pain or we're talking about other etiologies or other causes of disease states, there frequently is a preventative aspect that may be able to give some degree of benefit. And what I mean by that, let me be absolutely clear, is not saying that the pain is the patient's fault. And I'm also not saying it's all in their head. But more so, there are certain things that as doctors, as physicians, as mid-level providers, we need to take and help patients empower themselves and say, how can we give you some of your own autonomy back? To say this isn't something that has just grabbed you and taken hold of you and you just got to ride the wave for what's there. No, it's a way that you can be able to direct this, a way that you can be able to say, you know what? There are things that I can do to help improve my own current state. And those type of things are, how can I be able to improve my overall fitness level? How can I be able to improve my diet? How can I change some of the things that I might have in terms of if I'm larger in size? How can I be able to deal with the aspect of using smoking or other substances that are working directly against my possible improvement? Traditionally, when you look at the picture on the left-hand side, we deploy 88% of our medical services towards a problem that is limited in nature and has very few potential outcomes on health determinants, where the vast majority are behaviors that we can influence. And that holds true for the aspect of pain as well. And all of this is not hubbub. It's not a bunch of hooey. It's actually been tested and evaluated and trended in the New England Journal of Medicine back in 2007. So a number of years or so ago. But the medical institution as a whole hasn't necessarily really grabbed that and said, you know what? We're going to use treatment therapies that actually take this into account. So one of the methodologies of being able to really look at that is something like multimodal treatment. This isn't something I came up with. This is something that's been out for years. The problem and the issue is, can we really be able to employ this, and how can we leverage a really demanding healthcare situation that states we have to get in, see a patient quickly, and then we have to get out? Well, some of that assumption is that our time is really truly limited, and maybe we can be able to look at it from a couple different dynamics on how to be able to maximize that. But when we look at this picture, the top 3 circles are circles that have been validated and are used in traditional pain management, pain treatment, other surgical interventions as mainstays, meaning we look at pharmacotherapy. All right, so let's fix it with the medication, or let's fix it with the interventional approaches, which are some of the things that we excel in, or let's fix it with physical therapy and functional treatment. Those things are good. However, they are not the end all be all towards treatment. Some of the other things that we really need to look at are things like psychological support, are things like lifestyle changes, are things like complementary and alternative medicine. And if I can diverge for just one quick second, one of the things that I would say is that now, with the most recent advent of the opioid crisis, it's much more common to say, let's look at some of these modalities. But the fact of the matter is, most physicians, most healthcare systems really still haven't done it. And so what we really have to do is to take this on a case-by-case basis and find ways to empower patients themselves to take control, to be able to give them the tools that say, how can I evaluate my own state? How can I evaluate my own disease? And how can I be able to diminish how this impacts me so I can get back to doing the things that I really want to be able to do? So to that end, one of the things that we really look to do is to say, how can we utilize something like integrative medicine in order to be able to improve potential outcomes? And so integrative medicine is that aspect of combining all those things that we saw in that one picture earlier. How do we use physical therapy? How do we use interventional pain therapies, which we use with some degree of facility? We value and really pride ourselves on being, quote unquote, one of the most cutting edge clinics that's present in the country. But in addition to that, we don't want to lose the thoughtfulness of saying, patients need counseling and coping skills, and we need to be able to employ those techniques in order to make patients be functional. Can we look at chiropractic care? Can we look at yoga? Can we look at nutrition? Can we look at mind-body connection and make all of those things one of the aspects of a compendium of different tools to make that patient be able to be the best person that they can be, and to use the traditional vernacular of living their best life? So one of the things that we look at is, in order to be able to improve something, we need to be able to measure it. And in that regard, we need to be able to say, okay, what is this patient's functionality? What can they do? How much can they bend their arm? How much can they move forward? How much can they stand for? How long can they be able to sit? Those are tools that we need to assess. All right, what's that patient's mood? What's their mindset? Are they depressed? Are they anxious? Is there a way for us to take that stigma of that assessment and evaluation away? Because most pain patients, despite what many people think, are not those individuals who are going to complain and whine and say, oh, I hurt today, I can't do anything. They don't want people looking at them with pity. More so, they will typically bury what is going on from a mental state, from an emotional state, and not allow that to be really evaluated, assessed, and treated, even if it ends up being one of the best things that could possibly happen for them. Number 3, are we looking at sleep? Are we evaluating potential detriments to it? And how are we being able to assess that? And number 4, when we think about the aspect of opioids, if they are needing to be employed prior to us using it, if we use it at all, are we assessing for risk of addiction? All those things need to be evaluated and assessed, and it's frequent that we don't do those things. And that is the context of integrative medicine as shown in that previous slide. Can we be able to say, let's evaluate this, let's assess it, and figure out how we can be able to improve it? So our practice at Cutting Edge Integrative Pain Centers does all of the above. We really try to use regenerative medicine as a way to give patients their life back without them having to use surgery. Not saying surgery is the evil empire and there's never a potential option. There are times where surgery is necessary, but those times are probably less than what we actually really give it credit for. So we use different techniques in order to be able to deal with that. Are we able to then be able to plug that patient into integrative wellness type treatments that allow for them to have a sustainable ability to be able to function for a long period of time? And are we assessing those individuals for both the aspect of their mood, their mindset, and their cerebral functioning, and really tapping into how can we make that patient be able to do the things that they really want to be able to do. So one of the things that my practice started to employ and had the good fortune of being able to connect with was an app that's called NeuroFlow. It was developed by a CEO who was a West Point graduate who did 5 years in the Army and a tour in Iraq. And when he came back, he found a number of other veterans as well as civilians that really had gaps in being able to connect to behavioral health specialists. And their mental health was impacting their functioning and their well-being. And he said, this is not the way things should be. We need to find a way to be able to improve this and do this in a better method. And one of the reasons why is because we see that chronic pain is linked to things like sleep disturbances, to fatigue, to trouble concentrating, to appetite being decreased, towards restricted mobility, to being dependent on opioids, to having increased anxiety, to having lower quality of life. And what we see is that chronic pain patients are 4 times more likely to develop a mental illness than those without. So if we know all these things, how can we really be able to evaluate this? And what they were able to formulate is a way that you can either have on a smartphone or on a web basis, on a desktop functionality, that patients can be able to track their mood, their sleep, their stress levels, and all those things that they track is reported back to the physician, to the clinician that says, okay, now we have context for when we do certain treatments through whatever mechanism, do we have an understanding of how that impacts the person? It's really, in some ways, common sense. What we normally do is get a snapshot of bringing that patient back into the office maybe once every month, maybe once every 3 months, maybe once every 6 months. And then we're trying to see what our different treatments did, and we have no contextual understanding for that because we don't know on a day-to-day basis how this really impacted this person, and it's not really giving us true good data. In addition to being able to get the data, we also want to see how's that patient functioning? What are they recording in terms of the qualitative piece? Are they giving a journal entry that gives us understanding? We've historically talked about having patients use pain journals, but most of the time, those pain journals never really come up in the topic of discussion in an office visit. What we need to do is to bridge that gap so that the qualitative and quantitative pieces are all intermingled for us then to put together a treatment plan that allows for patients to be able to get better based off of what we were able to understand. And finally, right then and there, are we allowing patients to say, what tools can they employ without us, without healthcare, to give them hope to say, all right, you know what, we can practice guided breathing. This app can be able to help me change what my breathing pattern might be, which might change my heart rate variability, which may have an impact on my sympathetic system that allows for my pain to be able to be reduced. Those are things that app, when utilized appropriately for patients, it gives them the ability to be able to take care of themselves in addition to having their provider be more informed. Fortunately, by having the utilization of our patients with this, we were recognized nationally as one of the few pain groups that has been able to collect data and improve patients' mental health when they needed it most, when they're in a dire pain state. So what's the point of this whole aspect of the video? The point is we have patients that have challenges, that have issues with being able to do the things that they really want to be able to do. And old tools are not the best tools. There are ways for us to say, let's do better than what we've done. And I would challenge my healthcare colleagues, as well as give hope to pain patients to say, there are different ways, there are cutting edge ways, and those are the things that we should utilize in order to make people's lives better. Thank you so much for listening to this lecture. Have a great day.